Hello, my name's Anthony Effinger. I'm the host of the Think Neuro podcast at the Pacific Neuroscience Institute. And today I am talking with Dr. Garni Barkhoudarian, who is the co-director of the Pacific Pituitary Disorders Center, the director of the Pacific Adult Hydrocephalus Center, and the Pacific Facial Pain Center, and the Neuroanatomy and Surgical Skills Lab. So he is very busy and he's taking time to talk to us. Thanks for joining us.
Thank you. It's a pleasure.
So we talked about a year ago at the beginning of this pandemic.
Right.
What has it been like to do brain surgery during COVID?
Well, it's been interesting, to say the least. COVID was obviously very disruptive and, of course, had a lot of challenges for the patients who were suffering with the disease. But it also led to a number of logistical issues that we were dealing with in the hospital. Something as simple as just having enough beds for patients, having enough intensive care unit beds for patients, patients that typically, our neurosurgical patients would often go to the intensive care unit at that time. And then other things like worrying about the safety of the patients contracting the virus in the hospital, worrying about the safety of the caregivers in the operating room, the nurses, the people taking care of the patients. So all of that was of significant concern pre-vaccine, and actually continues to be a concern post-vaccine due to issues that we can talk about.
The Delta variant?
The Delta variant, but probably more importantly, the lack of complete vaccination. Mm-hmm. That's a major issue that we were worried about and has started to show its ugly head. Yeah.
So where do you think we are now? Are we going back to where we were a year ago?
Well, we're not that bad. We're not as bad as it was back in March of last year, or the worst was actually December, January, where Los Angeles, Southern California had a horrible surge.
I remember.
That was akin to the New York surge at the beginning of the pandemic. And that was where people, the hospitals were so full of patients who were so sick and requiring long-term ventilation that we did not have space for our other patients who needed sometimes urgent surgery, and it affected certain patients' health.
Oh, certainly.
And we definitely know of patients who had delayed care either from their own volition or due to hospital capacity issues. And it definitely was a detriment to patient care.
And we're talking about brain surgery here.
We're talking about any surgery, including brain surgery. Yeah. And, a lot of what we do is brain tumors, and there's some urgency for brain tumors, particularly malignant tumors. And, we definitely had some cases where patients either themselves delayed seeking care because of the emergency rooms being full, or they were afraid of going to the emergency room, rightfully so, or the fact that there just wasn't space in the hospital, and the OR was asking us to pick and choose which cases to do. If a patient was thought to need to go to the intensive care unit after surgery, they would ask us not to do that operation because there were no beds available. And we have a relatively large number of intensive care unit beds for our hospital size. And even with that, and its expansion, we were still dealing with those types of triaging care for certain types of patients.
So COVID was crowding out other patients.
Correct. COVID infected patients were crowding out other patients. Exactly.
Yeah. So where are we? When the population of patients that you see, what do they look like? Vaccine versus no vaccine? What's it look like?
What percentage are vaccinated? Thankfully, for my patient population, the vast majority of our patients are vaccinated. Part of that is we live on the west side of Los Angeles, and most people on the west side tend to be more vaccinated. If you go farther inland or north into Central California, you'll see a lot of unvaccinated patients. And we do operate on patients who come in from, say, Central California, Central Valley, Inland Empire, et cetera. And those patients often are not vaccinated volitionally. And we have to deal with that aspect.
So what do you do? I mean...
Well, we take care of the patient, obviously. We test everybody. We make sure that they don't have COVID on them. And if they do have COVID and their surgery can wait, then we ask them to wait 3 weeks for surgery. If their surgery can't wait, then we take the additional level of precautions. Everybody wears N95 masks, including the caregivers. And there are certain precautions we take in the operating room. And then we take these patients to the OR. And I've done that a few times, even after the vaccine has been out. And then we also encourage patients to get vaccinated. And, for some patients, there are some medical reasons not to get vaccinated. Say you're immunosuppressed due to cancer therapy, et cetera. But the vast majority of patients are able to get vaccinated and should get vaccinated.
And we have a lot of reluctance.
We have a lot of reluctance that's quite unfounded. I think there's if you talk to patients who are unvaccinated, while you would think the biggest factor is political, it's actually more just this skepticism of the safety of the vaccine. But we have plenty of data to show that the existing vaccines we have in the United States are very safe. Every vaccine, there's always a possibility of side effects. That was the same case with the flu vaccine, the same case with the chickenpox vaccine. There's always a possibility of side effects. But those are a minority. We're talking a fraction of a percent of patients would get a possible side effect. Whereas we know that patients who contract COVID, there's about a 2% chance of dying just up front. And then there's about probably a 15, 20, 25% chance of long-term major physiologic problems. And we see that the long haulers, as they say, have pulmonary problems, so they become short of breath. They are not able to get to the same physical capacity that they used to have. And we're talking athletic people that are just now incapacitated. There's COVID-related brain issues.
Yeah, let's talk about that. I was going to ask.
Yeah.
What are you seeing?
Well, the most common thing we have seen are related to vascular issues. So meaning people are getting strokes while dealing with COVID, and then they have to deal with the long-term issues of those strokes.
Okay.
So that's probably the most common thing we've seen with COVID.
Why does COVID lead to stroke?
Well, that has to do with how the virus interacts with the blood vessels, but the virus has a way of getting into the blood vessels and also working with the clotting cells to the point where they're just not functional, and then you get this hypercoagulable state.
What does that mean?
Prone to clotting.
Okay.
Prone to clotting. And then as a result, when you're very sick, in particular during the cytokine storm that happens about a week to 10 days after the infection, then your patients are prone to strokes or heart attacks or other sort of pro-clotting type problems that can happen.
Okay.
And so
then you've got this stroke to deal with.
Then you have a stroke to deal with, and you may recover from
right.
COVID. COVID's gone in your body, but you may have a devastating stroke. And we've seen that in a number of patients. We've also seen some non-specific findings on MRIs where a patient comes in, has some mild complaints, maybe some headaches, maybe some brain fog, and the MRI shows some non-specific abnormalities in the brain. And we're still learning about that. We're still trying to understand what that means in the long term, what that means for how to treat that patient. But you can tell that in a percentage of patients, they do have some brain-related issues even after their disease is gone.
We really don't know what this virus seems to affect every system in the body in some way or another. I mean,
it affects every system in the body.
We're just learning all these things.
And we've learned a bit about, in the year and a half that we've been dealing with it, we've learned quite a bit, but we don't know what the implications are 5 years from now, 10 years from now.
Yeah.
And interestingly, that's the same concern from hesitant patients who don't want to get the vaccine. They are worried that they don't know the 1 year or 10-year issues after the vaccine. But the general philosophy, and my philosophy, is you have a disease that can kill you and can cause long-term problems. And you have a vaccine that works very well and has a really small chance of any sort of long-term issues. And most patients who got the vaccine, myself included, done fine.
Yeah.
And I think the decision is very obvious. I would choose the lesser of the two evils. The vaccine is really fantastic. It does a great job. People who are vaccinated, who are getting the new variants of COVID, the Delta variant, which is a lot more contagious than the prior variants.
How much more contagious is this thing in your estimation?
I've heard upwards of 100 times or even 1,000 times more contagious than the first variants of the COVID virus, SARS-CoV-2 virus from last March. Now, I don't know what that really translates to. It's more contagious, meaning it's easier to transmit, and sometimes even the standard masks may not work very well, and N95 would be more safety for a patient of concern. But we're still trying to understand how aggressive it is.
Yeah.
It appears that the vaccine works, meaning that you can still get the virus with being vaccinated, but you don't get that severe illness, that long-term issue. It's a lot more blunted, but it is still a possibility of getting it. So this is why we are recommending staying masked indoors, and also to take all the typical precautions we had been doing prior to the vaccine rollout, but at the same time recommending everyone to get vaccinated.
Oh, God, yeah.
And already the state of California has announced that its employees, the state employees, will be mandated to get vaccinated sometime very soon. The Veterans Affairs system, so VA hospitals and the systems, are requiring vaccine mandates. And I just heard yesterday that the federal government is now going to require vaccine mandates for all federal employees. And this has been vetted through the Department of Justice, and the Department of Justice is recognizing that this is lawful in this pandemic state to be able to do that. And I think we're going to start seeing that in our health systems as well. We're going to start seeing our large health systems. I've heard University of California is thinking about this as well, their health system, and we're hoping that other health systems will start picking this up and mandate the vaccines for everybody that works for the health system.
I think it comes as a surprise to people who don't work in health that hasn't been the case already.
Yeah.
In Oregon, where I live, it's healthcare workers are not mandated to have the vaccine, which is surprising to me.
Yeah, I mean, there's some philosophical issues with regards to personal choice and dealing with some of those aspects, some of those ethical aspects. But the reality is this is a public health issue. And people are still getting sick. People are still dying from COVID. And it's still quite very serious. We're not out of it yet. And we really need to do everything possible to get to that 70, 80% vaccination mark. On the other side is the children who are unable to get vaccinated. So right now the vaccine is available for 12 years and older, but the 6 months to 12 years, we're still learning about that. That may come about down the line, but I don't think that'll happen during this surge that we're seeing right now. So I think that's something to consider, because even though you may feel you're safe because you're a healthy adult, you have to worry about your children. So you can have a fully vaccinated family, but the children could still be very vulnerable. And children get a different type of complication of COVID than adults. They typically don't have bad flu symptoms that they would from a COVID infection, but they do get this inflammatory thing called MIS-C. And that's an issue that we're seeing more and more frequently in children, and that can lead to long-term issues systemically for them for the rest of their lives, including things like aneurysms and heart blood vessels and some very serious issues.
And again, we won't know how this manifests itself in these kids.
Yeah, we don't know the long-term issues, but we also have seen some of these delayed issues in children. So it is definitely a concern. It's a concern that we still can't vaccinate our children. We want to do everything to protect them, and part of the way to protect them is to have all the adults vaccinated.
Right. So as a medical professional, highly trained, you had no hesitation about taking a new mRNA vaccine.
So I did my research, much like everyone else who has been learning about this disease over the last year and a half. I paid attention to all the publications that were coming out. There was a significant amount of information on YouTube, both from the government sources, from the scientists, and
good information on YouTube.
Good information describing how the virus works, describing how these vaccines work. The most convincing data to me was from the clinical trials. So I was one of the first people to get vaccinated. And I had no hesitancy getting vaccinated because I saw the data that was looking at, I think, 10 or 20,000 people who were vaccinated with either the Pfizer or the Moderna vaccine, and it showed the safety profile was fantastic. There's very few side effects, basically no major issues. And then we also saw that the chance of getting a COVID infection that was symptomatic with the vaccines was, less than 5%. I mean, it was very, very effective. And so that was a no-brainer for me to go forward with that. And I did get some side effects when I got vaccinated, like everybody else did after my second dose. I got the Pfizer vaccine after the second dose. I got some flu-like symptoms that lasted for about a day, and then it went away.
Yeah.
And that was it.
Yeah, the same with me and Moderna.
Yeah, and that's fine, and that's totally expected. And I think the question is going to be, do we need to update the vaccine to deal with the new variants? I think
Booster?
Yeah, a booster shot. I think Moderna and Pfizer are working on maybe a different formulation, or maybe they still stick with their original formulation, just boost the immunity. So those are all really important things to look into in the next round, which is probably going to be in the next month or two.
The next round, you mean the next?
Well, we haven't gotten much guidance as to should there be a booster shot.
Okay.
And if so, when? But most people had estimated that the protection from this vaccine would last somewhere between 6 to 9 months, and we're basically there.
I see.
So I think there's some serious discussions about this, and hopefully we'll hear from the CDC and other authoritative agencies as to which way we need to go.
What is the reaction when you tell an unvaccinated patient, when you advise them to get the vaccine? Do they hear you?
So when they're my patient, they tend to listen more.
Yeah.
There's already a relationship there. And some of them have some logic to why they're not vaccinated. Say they're on steroids and they're immunosuppressed. I think that's logical. If you're immunosuppressed, the vaccine just may not work.
Right.
So that I understand. And that's a unique, specific, and a minority of patients have that issue. But some patients were against the vaccine due to the things we talked about. And there, I sit down, I explain to them, we talk about how we're vaccinated, I discuss the statistics. One key statistic is that of all the patients who are hospitalized due to COVID, 98% of these patients are not vaccinated. I mean, that is basically black and white, that the vaccine is doing a good job. It doesn't prevent spread as much as we would like, but it does prevent severe disease. And that's really what we want. We want to prevent people from getting so sick that they have to get hospitalized, they have to get intubated so that they have a machine breathing for them, or they even worse, they have to get on a heart-lung machine where the blood supply is circulated artificially so that we can boost the oxygenation because the lungs are just not working. And so those are things that we are seeing drop off when people get vaccinated.
Yeah. So that's got to be compelling to people when they hear these sorts of things.
I think it's compelling. I think people are starting to, the people that were hesitant from a safety perspective on the vaccine are starting to turn around and come around. But I just read this morning that the vaccination percentage is still only about 57%. And that's just not enough. We really need to be upwards of 70, 80%. So there's about 20 or 30 million people or more, if I do my math right, that still need to be convinced on this. And then thankfully, some of the political aspects are starting to melt away a little bit. I was happy to see President Trump encourage people to get vaccinated. I think this was over the weekend. I think most political leaders are now encouraging everyone to get vaccinated. We heard the governor of Alabama dealing with that as well. So I'm glad to see that this is becoming less and less of a political issue, and hopefully people will ignore that aspect and just move forward. I think people should remember that this was a bipartisan effort, and the vaccine was really developed with everybody's input and everybody's endorsement. And so this is really an American effort, and we really need to encourage everybody that this is just for the safety of the country and for the world, that we just need to get vaccinated.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/ Foundation.
The development of the vaccine was sort of a biomedical miracle if you look back at how long it usually takes. Remember, we were talking about not having a vaccine for 5 years or something.
Yeah,
Just a year ago.
It's fascinating. And so I was actually talking to somebody about this a week or so ago. You know, if you look back at the achievements that we have made over the last 100 years, and you just think of the biggest ones, you know, I would say landing on the moon, huge achievement. The internet, huge achievement. Mapping the human genome, huge achievement, right? Things that were moonshots that were thought to be impossible. And then there was the coronavirus, which is a common cold virus that people have tried for 150 years to make vaccines against the common cold, and people gave up because it was so hard. And then SARS came out in 2003 in China, and that's the same coronavirus family. And then people, again, tried to do it again. They tried to make a vaccine against the SARS, the coronavirus, the SARS virus at that time. And they failed. They tried for a number of years, millions and millions of dollars of NIH funding went to this, and they couldn't do it. It was not possible. And then at that time, the SARS went away. And then we had another uptick in 2011 with MERS, which is another cousin of SARS. And then that went away. So nobody was putting a lot of effort into it at the level we did recently. But it goes to show that if you have a concerted effort and if you have enough resources, I mean, literally billions of dollars was spent on developing this vaccine and actually trillions of dollars dealing with the pandemic, then it is possible. And we did something, we the scientists did something that was really thinking outside the box, a different type of vaccination philosophy, different type of vaccination approach. And it's amazing that we have this vaccine, and we have it, I think within 12 months, no, what am I saying? Within 9 months of the pandemic, we have a vaccine.
Yeah.
That is unheard of.
Unheard of.
Even for other types of vaccines like chickenpox, like measles, like mumps. That takes about 4 years on average for the vaccine to be perfected and to get to the point that it can actually work. And here we have a functional vaccine that works very well.
Better than most flu vaccines.
Better than
Right?
most flu vaccines. And in 9 months. That's
Yeah.
just phenomenal.
Yeah.
And so I'm very proud to be able to work with scientists and physicians who have led the effort on this. And it's just an amazing feat of modern medicine. And I think we really need to embrace it.
And now we just need to get the public health part of it right.
People are working on it. It's going to happen,
Yeah.
but it's just happening too slowly. And we're going to see another surge. We're in the middle of another surge right now, and it's going to get bad. But ironically, it's going to affect people who are not vaccinated much more than people that are vaccinated.
Yeah. There's going to be half the nation's going to have a pandemic.
Yeah. So I do want to talk a little bit about some of our neurosurgical
Please,
experiences.
yes.
You know, as we were talking about, the hospital had limited number of beds. And yet we still had patients to take care of. We had brain tumor patients, brain cancer patients, and other types of patients that were sick and they needed surgery. And we didn't want to turn them away. And we had to get a little creative in our approach. And while this is not a new thing, we've actually pushed the envelope a bit in regards to where a patient actually needs to go after surgery. So the traditional approach is that if a patient has a brain tumor, they go to the intensive care unit, they're observed there overnight or maybe even a couple of days, and then after they're deemed healthy, then they go to a lower acuity bed in the hospital. They're there for another couple of days, and then they go home and they convalesce at home, and then they're back to rehab, back to their normal lives. And so that's 2 to 4 days in the hospital or longer, and utilizing the intensive care unit for 1 or 2 days.
Which is impressive.
Which is actually better than it was 5 or 10 years ago,
yeah.
but still that was the comfort zone for California, United States brain surgery.
Okay.
Now in Canada, there are people who are doing outpatient brain tumor surgery, meaning they go home the same day, and they're able to do it because they educate their patients and the patients are motivated to do that. Here, we tried to do that a few years ago, but There was this concern of the safety of having somebody leave so early, and patients were not motivated.
How do you educate patients to shorten that stay?
You have to, number one, there's a lot of conversation before we even enter into the operating room. So what to expect in the hospitalization, what to expect in surgery, what to expect afterwards, how your pain will be, how to manage that pain. We effectively give them all of the discharge instructions before they even have the surgery so they know what to expect. And then we also tell them, if you do these things, the likelihood of your pain being bad is very low. And we're not talking about narcotics, we're talking about some basic things that can be done. And then we talk about mobility, we talk about getting them up and moving them around. And the literature is supporting this philosophy to decrease postoperative complications. The worst thing is
get people out of the hospital to
get people out of bed.
Get people out of bed.
The biggest risk factor for a patient after surgery is them lying in bed and not moving.
And deconditioning.
They get deconditioned. Their lungs don't reinflate, which means that they are more fatigued. They may not ventilate very well. They're not getting air into their body very well. And as a result, they may even be at risk of developing pneumonias. Also, because they're not moving their arms or their legs, they're at risk of deep vein thrombosis, the clots in the veins that can travel and cause problems to their legs or arms, or also travel to the lungs and cause problems to the lungs, what's called a pulmonary embolism, which could be fatal. So we've known this for many, many years, that by getting somebody to walk right after surgery, the same day after surgery, actually increases their circulation, gets the muscles contracting, and gets the blood flowing, and decreases those chances of developing a deep vein thrombosis. So in patients who can and are safe to do that, we encourage that. We also encourage them to use a breathing apparatus to help reinflate their lungs, and some other activities like that. That same maneuver also decreases pain postoperatively for cranial procedures because they're standing up, so there's less blood flow.
Interesting.
And so they have less pressure.
That simple thing.
That simple thing. And it also decreases some of the wound healing complications because when you lie flat, pressure goes up to the head. You can affect the seal of the repair that we had done. Whereas when you're up and moving around, that pressure goes down. It actually lets the seal work better. So our complications such as cerebrospinal fluid leakage, or CSF, which is the brain fluid that bathes the brain, that risk goes down significantly just by getting them up and moving them around. And this is not new. This has been published. Our colleagues in Italy have published on this, on a specific type of surgery. But this is something that is part of the bigger picture of getting people up and moving around.
When did the get up and moving approach start?
Well, that's been going on for a few decades.
Okay.
This is not new. But getting them up so quickly. The same day, probably in the last 10 years, 15 years, that has become more commonly accepted. And really in the last 5 or 10 years, particularly in this era of what's called enhanced recovery after surgery, or ERAS, which is really the idea is to prevent complications or decrease complication rates. And as a result, patients are going home sooner.
Yeah.
And so that was what we found. And as a result of patients being motivated because they don't want to be in the hospital any longer than they need to, and people were asking, can I get my brain surgery done as an outpatient? Whereas
it's amazing to even say that.
Yeah.
I mean, that phrase alone is impressive.
I mean, before, patients were saying, I'm going to be in the hospital for a week, right? Keep me as long as you want. And now they're saying, well, I want to get home as soon as possible. And so now patients are motivated. And as a result, we've seen our patients shift so that the percentage of patients that need the intensive care unit was cut in half or lower. And we had a number of patients that were going home the same day after surgeries that were typically would keep a patient in the hospital for at least a few days.
What sort of surgeries are those?
Brain tumor operations, primarily pituitary tumor operations. So that would include things like metastatic brain tumors, meningiomas, gliomas, things like that.
Is it? Are they more likely to go home sooner if you do minimally invasive keyhole surgeries?
I think that's part of it. It's part of the bigger picture, and that's a philosophy we have here at Pacific Neuroscience Institute. The idea is that it's multifold, but the idea is that because you're not manipulating much tissue on the scalp, the pain is less. So you have less of the skin causing pain or the muscles that were dissected causing pain.
Muscles
There's muscles on
Yeah.
the head, the chewing muscles, and there's also muscles that are the muscles of facial expression, like your forehead muscles, and there's some in the back, and sometimes that can trigger pain. Additionally, because we're not exposing a significant amount of brain, because we're operating through a keyhole, basically, very little brain is being manipulated. And when there's less brain being manipulated, that brain recovers much quicker. So it wasn't uncommon to see patients wanting to be able to leave within 1 or 2 days after surgery. We just now act on it.
Yeah.
But now we're saying, okay, yeah, you look fine. You want to go home the next day? That's totally fine. You want to go home the same day, and we have certain metrics that they have to meet. There's some safety things we want to assess. If they look fine and they know how to alert us if there's any issues from home, then we let them go home.
So you could come into the hospital, say at 6 in the morning, or surgeries always seem to be very early.
Yeah. They come in at 5 a.m. for a 7 a.m. surgery, and theoretically they can be home by 5 p.m.
That's incredible.
Yeah.
And that's happening more and more.
That's happening more and more. Yeah.
And the theory also is that the less time in the hospital, the less time you risk infection. And is that correct?
Less time in the hospital. So we haven't seen a patient catch COVID at our hospital.
Oh, COVID particularly, yeah.
But we do know that if you're in bed and you're just in the hospital for a few days, there's a chance of getting urinary tract infections and pneumonias and things like that. That comes with the territory. But yeah, now we see them mobilizing more. And then the other advantage is that we're freeing up more beds for patients that are sick with COVID or have other issues like heart attacks and other typical things that bring a patient to the hospital. And those patients are able to utilize the beds more frequently. And it just creates a better throughput, better workflow in the hospital.
Fantastic. Yeah.
So regarding the patients that were able to leave the hospital sooner, we were having patients go home the same day or the next day. So we actually were able to publish this data. And this will be coming out in a journal called PLOS-1, PLOS-1. And it'll show how our team has adapted to the COVID pandemic. And some good has come out of it, which means that even after the COVID pandemic ends, we will still have this ability to accelerate surgical care and not utilize as much resources in the hospital and get patients home in a safe way and a reliable way.
Yeah. So there's the silver lining.
Yes.
To COVID.
A little bit of silver lining.
A little bit.
Yeah.
But we'll take it.
We'll take it.
Do you still have a backlog of surgeries that are caused by COVID, or have you?
No, we are functioning well right now.
Everything's moving.
Thankfully, right now our ICU has capacity and our ORs have capacity, and we're working well. But back during the surge in December and January, we did have a backlog of a few months. And we for elective and even non-elective operations, we had to wait. And we had to really pick and choose and triage patients appropriately so that we knew exactly which ones needed surgery urgently because there was a cancer that we needed to deal with or there was impending neurological problems. We actually created an entire triage system to determine this. Providence Health System had this across all of the hospitals, how to determine which patient gets priority when we had to make that decision. And we followed that. And then, of course, there was a lot of discussion with the intensive care unit team, the hospital administration, discussing, why would this particular patient needed to go. And there was a whole committee that had to review those types of cases.
It's such a juggling act.
Yeah.
And hopefully we don't return to that.
Well, that's the concern. And right now we're not there yet. But should this surge continue, we may get back to that point within the next few weeks. So this is why it's quite important for people to mask right now. It's also very important for people who are not vaccinated to get vaccinated.
Yeah, that's the message.
And the vaccine takes a while to work. It takes about 6 weeks.
6 weeks.
So say you take the Pfizer's probably the fastest because you take the Pfizer first dose, Pfizer second dose 3 weeks afterwards. It takes another 2 weeks for the immunity to really build up. So about 5 weeks after the Pfizer vaccine, you should be well protected. I think Moderna, it would be 6 weeks.
Just because of the spacing on that.
Yeah. And also Johnson & Johnson is about 6 weeks, just the way, even though it's a single dose, just the way that's formulated, it just takes time for that immunity to build up to a threshold that will be protective.
Yeah.
So I encourage everyone to get vaccinated. But even then, we may not see the full protection of the vaccine for 6 weeks from now.
Yeah. What do you think is in it for people who are spreading misinformation about the vaccines?
Oh, that's a tough question to
Yeah.
answer. I don't know many people who are spreading misinformation. I think it's probably driven by a multitude of factors. Probably there's some political aspects. There's clearly a component of people who are concerned about their civil liberties being trampled upon. And I understand that. I mean,
Sure.
I'm not one to like being told what to do. You know, I grew up in a household like that, but I'm glad that is not there. But I think that I think a lot of people share that concern. I think those people just need to understand that this is for the betterment of everyone around them. It's not just about them. It's
Yeah.
about their friends, their family, their children. And quite frankly, if we want this country to open up again and to get our economy really back on track and stop relying on the government printing money to continue keep this economy going, then we need to do this. And that will keep our country in a very healthy situation when the pandemic ends,
Yeah.
compared to other countries. So I really think that this is a global issue that needs to be dealt with.
Yeah, absolutely.
Yeah.
I just heard about one of these pieces of misinformation that are going around, and that the spike protein in the vaccine is invading the brain somehow and is causing irreparable damage.
I can tell you that that's not true. The science that we have, that we look at the way the vaccine is delivered by the particles within the vaccine, it doesn't cause any long-term issues because that spike protein lasts for a few hours. It's the antibodies that need to be generated from seeing that protein. That's what really is helpful. So what's happening is, and the reason we do see some of the side effects after the vaccine is that your immune system is ramping up. And your immune system is ramping up because it sees a new problem and it's like, okay, I gotta figure it out. So the first dose, you get a little bit of that antibody. The second dose, those B cells are already trained and they're like, oh yeah, I got to work on that. And then it amplifies the number of B cells that are going to use that antibody and produce that antibody. And that ramped up immunity, that ramped up immune system is the reason why we see some people with headaches, some people with joint pain, some people with abdominal issues. You know, we do see all of that and fevers as a response to the vaccine. So it's not because the spike protein is invading and doing anything. It's doing its job and it goes away.
It goes away.
That mRNA lasts for hours. That's it.
So that's it. It's
Yeah.
just what's left is the response in the body.
Yeah. So that's what we
people
want.
don't know that.
Well, if they listen to what the government is saying, and if they listen to what the scientists are saying, who are not employed by the government, they can see that that's out there. And I think that people tend to pick and choose what they want to hear. And this day and age is very easy to do that because of the way Facebook and Google works, is they show you what you want to hear. And as a result, you can get very sheltered and insulated from the facts out there. And I
you
think
go
it's
down terrible rabbit holes.
yeah. And so what I tell my colleagues is that we just have to be the voice of science and medicine, and we have to continually discuss this issue, continually talk about the facts, and maybe it may not affect everybody, it may not influence everybody, maybe it influences enough people to start looking at a different source of information, and they can come to their conclusions over time.
Yeah, absolutely. Dr. Barkadarian, it's been a pleasure once again.
It's always a pleasure.
Yeah,
Thank you for
delightful.
having me.
Thank you.